So, good evening, everybody, and welcome to this fourth of our webinar in a series which we are conducting in the name of preparedness for the third wave. ISCCM per se has been on the forefront for preparing the programs for training their healthcare workers. So, what we have thought that we are going to make a basic and advanced program for training all the healthcare workers who had never been exposed to the pandemics or ICU kind of environment. So, and that are precisely the reason we wanted to do this webinar, to take an idea and discuss what all we should include in this program. And very quickly after this discussion, we are going to formulate this one-day basics and probably 2 days of the advanced program for training our healthcare workers for preparing to fight any pandemics, and particularly keeping in the mind the current third wave. To discuss these issues, we have eminent panelists, Dr. Kapadia from Hindu Hospital, who is the past president also, Professor George Hidalgo, who represents the World Federation as well as SCCM and dear friend, and Dr. Prakash Shastri from Gangaram Hospital has been on the front runner for designing lots of programs for ISCCM. Nursing program is his brainchild, and he has contributed immensely for that. Dr. Deepak Gupta, current president, and he represents Vedanta as the director of the critical care unit. Dr. Pradeep Bhattacharya, with the vice chancellor and professor in critical care at Ranchi. And Dr. S. Javeri is at Regency Hospital, Lucknow. Dr. Arindam Kar, who is General Secretary, is going to coordinate because primarily it was his concept. So I thought that we should discuss this with the eminent panelists, and we may get some opinion from audience also, their question, and that will help us in formulating this program. So Arindam, over to you for this. Thank you.
Good evening, everyone. We have an hour-long program, so rather than directly going to that only just topics, I thought that it would be nice that if we have some certain discussion about the overall changes that had happened due to the pandemic, and then and very quickly I would come to the point of COVID-related courses and take your opinion and incorporate them into our scheme of things. So, and this would be an open forum. So every of the eminent panelists, please feel free to contribute, to give your opinion, to give your point of view. And there are no certain directed questions to any individual. So please feel free to give your opinion and let the discussion flow freely. So I would start with a very basic question, right? That the pandemic has reshaped every form of life. So in your opinion, how much it has reshaped the way we learn, our academic curriculum as well as our practical learning? Is it a learning opportunity for the budding intensivist, or it had been an impediment? I would request Farhad sir to start, and then I will go to every one of you.
Well, it's definitely in general put intensive care in the spotlight like it's never been before, which is a good thing. I can really only speak for my hospital, and I don't think it's made too much of a difference in terms of the way we practice or anything. It's like we anyway had 4 units, and now we got 5 or 6 or 7 units, and we have to cover all of them.
Right, sir.
Obviously, we have to do things a little differently in terms of infection control and PPEs, but overall, I don't think it's changed anything a lot, except that the COVID ICU is much more closed than the other ICUs. Consultants are not greatly enthusiastic about coming in. So getting things like echoes and Dopplers, which we do ourselves, has become much more routine, much faster, much more on-site. So paradoxically, the COVID ICU can do things on-site faster than the other ICUs because we've to some extent become a little more self-sufficient. Frankly, other than that, I haven't seen too much change, at least in the way it's practiced. In terms of training and teaching, when we switched to online, other than that, not so much. I mean, online is a major shift, but leaving aside the fact that we're doing things online.
Right, I will come to that point, Zed, whether it has been a boon or bane. So I'll go to Dr. Shastri, sir. What do you think? What's your opinion? Had it helped us or it was an impediment?
It was an impediment for the simple reason that there was a chasm between the people who are working in the COVID, and especially I'm talking about the younger generation. By and large, somehow or other, I get a feeling that the younger generation, the residents who were working, they knew that we couldn't do without them across during this period. That was one pressure that we were put upon. The amount of work that needed to be put was literally huge, I would say, almost double than what we normally do. And during that time, of course, we were several people we could lean back upon to give us some kind of support. In this situation, when the number of hours that we were putting in were reduced, I'm not talking about myself personally, I'm talking about the younger people, because we as seniors could not afford to confine ourselves to the routine regimen of 8 to 5 or something of that kind. We had to be there as long as we were needed. But the juniors obviously kept to time, and we could not hold them back, because for the simple reason that they used to be on PP, and we can't put them on PP for longer than usual duration. So all in all, I would say that somehow or other, the work that was put in by people was more a mechanical work than a substantive work. And that perhaps I would call it as an impediment to education for learning from the patients whom we were treating. Number two, there were occasions in which I very reluctantly, I did mention to one of my residents that you spend time in my hospital, you didn't work for me. So to that extent, it was hugely disappointing. And I'm glad that this phase is over. It was a devastating experience.
Professor Jorge Hidalgo.
Yes, and thank you for the invitation. And as my colleagues say, definitely the pandemic and undoubtedly disrupt the way how we traditionally practice medicine. And in some ways, of course, it's been disappointing because we are, as we say, traditionally accustomed to go and see our patients, touch our patients, and then now we suddenly are forced to create new ways of learning, new ways of communicating with our students as well as with our patients. But again, as all new things brings things negative, but also it brings a lot of new opportunities.
So, Dr. Yash, say from Dr. Kapadia, he said that it was more pushed us towards self-dependence, and wherein Dr. Shastri said that the work was more of some type of a monotony or a compulsion on an A. Yeah. But in between this workplace, how the academics or the training part, the juniors.
I will straight away go to the academics.
Yes.
See, education is an opportunity. We all were so stressed until the time we started these online meetings and online educations. We had only one thing in mind, which was related to COVID work and COVID stress in our communities.
Right.
So this was a break from the monotony. This was a break for learning because we had to acquire a lot of new knowledge. Sadly, there was so much of information overload that we have to literally race against our own selves to take care of the huge space. There were some positives, but as everyone said, most negative. The best thing was digitalization of education. We had global audience as well we had global KOLs. We could learn from each other. Education was in fact democratized. It was free for all most of the times. Most of the conferences and meetings, even the large meetings, gone free. But the sad part was it was only a theoretical knowledge, and some pseudoscience was also doing the rounds with the science. There was some misconceptions that were floated at times which not had very huge evidence. So yes, theoretical part we could share a lot of knowledge with each other. But if we talk about skill part, communication, contextual critical care, bedside mannerism, patient care, this all was sadly missing. So I will like to quote William Osler. We all have heard him this quote in our MBBS days. He who studies medicine without book sails an uncharted sea, but who studies medicine without patient does not go to sea at all. So we had a lot of theoretical knowledge, but until COVID and other illnesses come to us, we had no clue what people have been talking about it. Yeah. You are mute, Arinder.
Pradeep sir.
Yes, I see it is an in between opportunity and impediment, because any new thing or any new disease which attacks, or any pandemic like COVID, which has come this time. Initially, it was in 2009 we saw dengue, and before the dengue fever, and then followed by swine flu. So all these things, they make us learn some new things, and also we change our practices a little bit. So every time they come and we change, we modify ourselves. So as far as practice is concerned in this COVID, I will say there was two things which I feel that which has gone against our will. That is, you see that the requirement of intensive care unit was so high that the whole hospital used to get converted to one type of patient and admitting only one type of patient. And all departments, every major departments you see are involved in managing only one kind of patient, and that is COVID and COVID. Whether it comes with a mild symptom or moderate symptoms, severe symptoms, and rest all, you see that different varieties of patient we used to get in different other times of the year. They're almost vanished. So we started doing a typed practice as far as COVID is concerned. So everyone is doing a typed practice. And the thing is that as far as respiratory critical care is concerned, I think we had learned a lot. And post-COVID, also the sequelae and symptoms which arise and syndromes which we saw, they also taught us many new things to learn. And I think the way is still, the learning is still going on, and it will take a long time to know in detail about all those things. As far as education is concerned, I'll say it is an impediment, because it has really put a great barrier as far as learning of undergraduates are concerned. Postgraduates, although they were working in the hospitals, they were doing all their clinical work. But as far as undergraduates are concerned, they were all doing everything online. So, and we know that in medical fraternity, learning online only gives you knowledge, and we always look for a skill, we look for attitude development, we look for communication development. All these things were gone, and side laboratory work, museum, working in, going to library, going through museums, seeing cases, bedside clinical management, all these things were lost in this COVID period. So it was bad for as far as learning, knowledge, and students are concerned, but it was obviously in between for as far as practices are concerned.
Very nicely answered, sir. And I will go to Dr. Deepak Govil, the president of the society, to give his viewpoints.
So, every coin has got two aspects. So this pandemic also gave us one opportunity, few opportunities and few impediments were there. The opportunity was biggest opportunity, as Dr. Farad has said, we came into limelight, we came into forefront. What I perceive as a critical care, that we are a service industry. So we cater mainly to physicians and surgeons, and we make their life easy while putting our midnight oil, burning our midnight oil in the ICU, so that they can go back to their home and sleep. But this pandemic has brought us to a leadership role. And in every hospital, the critical care became a leader of the hospital, and everybody was looking to the critical care, what is going on. Side by side, as everybody has said, there could be some impediment also to the learning, but everything has got some opportunity. I can very proudly say that this pandemic has given us so many learnings to our juniors. Now all the juniors can do CRRT, all the juniors can do this plasmapheresis, all the juniors can put the ECMO lines, because so much of the work was done in these pandemic. Number of patients were too high, and the life support system was used up to the maximal, up to its limit. And it gave opportunity to learning to everybody. And mind you, the majority of time, the super specialists, so-called super specialists, were not coming to the COVID ICU. So that also gave us opportunity to learn and replace them. Now we can easily say that we are a multidisciplinary team in critical care, not as just a critical care physician. So that's it.
So we have learned to be self-dependent, as Farhad sir said, and also we have also reduced our over dependence on the super specialties, taking decisions, and majority of them are correct decisions on our own itself. And also a lot of life support or the continuation of organ support, that has been, the juniors have taken up they have got a huge opportunity to do that in a very short span of time, to see so many sicker patients in that span of time. So I think this was a major advantage that we already had. My next question would be to all of you, that as we are discussing all these things on an online or whatever may be a virtual meeting platform, do you think once this pandemic is over, and gladly so, all of us would be happy if it is over, right? So would it permanently change the way we communicate, or the way we communicate for our academic needs? Will this be the major way of communicating for academic sessions, or we will again go back to the traditional method? Yeah, sir, you would be always the person to conclude. Shastri sir, you can start, sir.
You want me to go first?
Shastri ji, for a change.
Oh, sorry. Go ahead.
Okay. Yes, I think I will have to accept that as far as communication is concerned, we have changed, if not a full circle, at least substantially. Even now, we have restarted our academic programs, and we are forced to do it in a hybrid manner, because we can't expect all students and all registrars and all consultants to be present at the same time in the department. So, but then they are very keen to attend. So we have now started doing all our academic programs in a hybrid format. And now we are seeing that moreover, across the world, the conferences and the meetings and everything is being held in an online format. And if you look a slightly bit outside, the entire IT industry is working from home. So, and we have also joined by doing online consultation. So the entire paradigm of the way we look at patients and the way patients look up to us, and that physical bonding that happens when we come and meet people and we talk to them, and then we convey our message, that has to be refashioned in such a way that even without that kind of a physical contact, we have to arrive at diagnosis, we have to arrive at a particular mode of treatment. So those things are something which people at my age would find it difficult to learn, but we don't have a choice. We have to go that way. And I think to some extent, the entire mode of communication has changed, and maybe changed for the good, as Yash pointed out, that most of it is free of cost. So a lot of people have the opportunity at least to log on and see. But having said that, Yash did mention about the various educational activities that was done during this period. And to the extent that we were almost put off, every time 8 o'clock in the evening, you would get a message that please log on and join this webinar. And every other day you would get invitations to join webinar. So, I mean, after a point, we just stopped looking at them. So maybe a bit, it was a barrage. But I believe over a period of time, things would settle down. But this thing
we would mature ourselves to filter it out.
Online is coming in a big way. And I digress from the topic a little bit and mention what happened in my house. My two sons were sitting at home and practically, just watching football matches on the television. And I don't know what happened to my younger son. And he said that I want to give GRE, and he enrolled in a GRE course. And we were taking it as a big kind of a joke that he was doing it, but he was actually doing it seriously. And then after that, he took money from me, I don't know how many dollars, from my credit card, and actually appeared for the examination. And lo and behold, he comes out as one of the toppers. So maybe just because he was locked in and he had to, do everything online, maybe he managed to do it. So I think now more and more people are coming around to the fact that, yes, that is the way forward. If you want to really educate yourself, online is the way forward.
Farhad sir, is it more difficult for the students or for us?
My next teaching session, I'll ask them which they prefer. I'm honestly very comfortable with both. I'm finding it difficult. A lot of my teaching sessions, which are in my department, are very interactive. When I ask a question, I expect everyone to commit to an answer before we move forward. That part is a little hard because you don't know if they are muted, they're not muted, they're listening, they're not listening. I'm learning how to handle that. I make the senior guy decide who's answering the next question. I keep them on and so on. So that interactive part, looking at people's faces to know whether they are getting what you're saying or not is lost. But it's not insurmountable. Do I think this is here to stay? I think definitely it's here to stay. It's just that I think now we'll have more options than we had before. I think online would have come, but it would have probably taken 5 or 10 years to penetrate. Now it's been rammed down our throats. And even once the epidemic is over, sometimes the students may say, let's do this online in the evening. Other times they might say, let's do this in the ICU or in the office. So I think the palette of options to teach will have expanded. And I can't see the online option disappear.
Professor Hidalgo, your viewpoint in your country and how you are managing it and how you envisage.
I think so. The technology definitely came to stay, and of course, with all the advantages of disadvantages at this point, I believe is more advantageous because, of course, we have the benefit of the flexibility on time and location. Also, we can bring the classroom to an online setting. Of course, is missing, and I believe that for all of us that train on a situation that we can see our patients, touch our patient, that part is missing. And we are rapidly transitioning during the pandemic and trying to see how we can adapt all these different practices. But it's been challenging, and I believe it's continued to be challenged. But I believe one of the things we are definitely learning from the pandemic is this collaborative effort to have to be the possibility for me being in the Americas and you guys over there, and that's is a huge opportunity and the foundation as how we can build our future, especially in education.
So it broke the barrier, it broke the distance barrier, the communication barrier and everywhere. And we had been able to connect to each other. And the flip side was where we were sometimes over-connected or overflown with it. Pradeep sir, your take on being in your medical college and heading an institution itself, one of the biggest institution in eastern part of India. So what do you think, how it had helped and how it actually had created some hindrance?
See, as I said, there are 4 things which actually matters when we call as far as medical learning is concerned. First is K, that is knowledge. The second is S, that is skill. And third is A, that is attitude learning. And fourth is learning of communication. So when we talk about knowledge, it is very good. When we say this Zoom meeting, virtual learning, everything, they are very good for the development of knowledge. So you develop your cognitive domain as far as medical learning is concerned. You always strengthen your cognitive part by going through virtual learning, video assisted learning and Zoom learning. But as far as the skill development of attitude and development of communication, they always lacks unless you go a physical in your rounds and go and see the patients, interact with people and interact with family members. All these things will lack. So as far as development of knowledge is concerned, definitely this virtual method and Zoom learning is very good. But for others, it will not help.
Very, very, very rightly summarized and said. Yes, very quickly.
Do you
think that simulations, right? And there are a lot of online simulations where from very distant, your circumstances, both the teacher and the student can interact. Do you think, though albeit they are quite costly at times, but do you think that can a little bit compensate for the lack of physical classes or the physical or the in-person classes?
See, we are good at propagating science with online forums, but sadly, the skill we are not able to propagate and educate our students to that extent as we could have done in person. So yes, there is an interface where the barriers have been broken, but there are some roadblocks. The skill part, the aptitude part, the communication, some of it could go away with online simulation. But as you rightly pointed out, the cost and the feel, unless we have that feel, that adrenaline rush in our own selves. See, simulation we all have done and we understand, we know it is not real. So we do not have that real life feel. And now if we go online simulation, that feel is further decreased. But still, if we have to compensate for skill part with online simulation, yes, it is one of the solutions and which should be utilized in a bigger way now.
Govil sir and Rajesh, both of your quick comments. Govil sir, unmute.
No, I don't have got anything much to add. I think everything has already been said, so it will be just a repetition. Dr. Shastri wants to say something.
I would ask Farhad to agree with me that our endeavor always has been to convert our registrars into potential consultants. And for that to happen, they have to cross a big chasm. And that is where perhaps our medical system, or for that matter, the methods of teaching fail. We have to convert the observed phenomena into some kind of decision making. Some people have the attitude and they make the transition almost without effort, and that they are the ones who are almost there in the panel right now. They go on to become very successful consultants. But there are quite a few, and majority, I would say, they fail to get this conversion done, and maybe they need to be handheld into this so-called transformation. And that is where I believe the online teaching does not help so much as the physical form of teaching. That is my only comment. And I'm sure Farhad would agree on that.
Farhad sir, your comment.
I should have said in the beginning, there are two big advantages of online. Is people who've left your institutes can also attend your sessions. That's one big. And the second is, I think of all the ISCCM webinars, the one I enjoyed the most was, because it was new to me, was the ECMO and transplant one. And I had the option of seeing it on YouTube at my own timing. You see, this is a very, very useful thing. Others, I would not be aware of it. Now, in terms of, I still feel that while we are teaching, we are also doing rounds where the teaching at the bedside has not stopped as far as I'm concerned through the pandemic. I'm only talking of the additional teaching over and above that, what happens in the ICU. And in that, it's okay. It's not that hard to do it outside. I'm not for 1 minute suggesting that the classroom or the online is the way to make doctors. No. In response to Dr. Shastri, I think each person makes that switch in their own time. And I think quite often they need to be thrown in at the deep end of a new job to do it. What I actually find concerning is when people have passed exams and are making that switch, they go into a slightly overconfident phase before reality hits them. They start making too many autonomous decisions, which are probably not right. So when a successful candidate is now doing rounds, my role now starts to rein them in a little bit rather than to this thing.
And just to add what everybody has said, that this pandemic has taught us, in fact, made everybody this thing acceptable format, that at least online has become a way to approach where you could not approach. A lot of quick suggestion you could get, lot of quick consulting you get. Just I give you a quick example. Last week I was traveling to my native place, and one of the sulfas poisoning patient was referred to me. Just quick. So he wanted that I should suggest, then only he will take, because I have treated previously, and the patient was perfect candidate for something. I said, like, you go to this hospital and I will be seeing. Has it not been a pandemic, probably nobody would have accepted that I will see the patient on video call and he will accept the treatment. This has become easier for us to convince the general public and even doctors and other also, okay, there are certain things which can be done on video call, not everything. And definitely a video call or online training, teaching is not a substitute Rather, is add on your armamentarium to reach more people and make those, like many times you see teaching. Not everybody can attend, somebody is off, somebody is on leave. But at least when you add this thing in your armamentarium, probably you can reach more people to teach. Probably webinar has helped us more in reaching worldwide.
And one to Rajesh Bhai, which Farad sir actually very aptly added, is that it may have reduced the disparity of training in different institutes.
Yeah, exactly.
So now the best teachers like Farad sir or Shastri sir or Deepak sir is available to all the 300 institutes that we are, where our courses are running. Right.
And
so through all
that is precisely the reason our webinars every day, I mean weekly we are doing webinar or teaching webinar, and they are so hit that at the end of the day, when you see the Facebook and all the thing, they're going in thousands of people are watching.
I will come to you to know about your future programs. You are leading our communications, that how you are thinking of increasing it. But now coming to the curriculum or the course or that we are running in different layers, be it a post MBBS course, be it a post MD course of the IDCCM or IFCCM, or the other courses of National Board or MCI. So do our panelists think that we should have a little bit look into the curriculum and also the process of assessment that we do? Do we need a little bit of change in it, or we are okay with it in the post-pandemic era? I will start with the Govil sir for a change, with he being the president, and he's been running all the courses. He had been being the examiner, the advisor to every possible committees. So, sir, your take on it.
I agree with Dr. Indam that little bit change in curriculum is needed. We need to increase the perception of any pandemic or any surge capacity building, any challenges which it can pose, because as we know, everybody was caught unguarded when it came to us this time. So probably little change in the curriculum will certainly help. Change in the curriculum, we should include the digital aspect also, telemedicine and the digital communication with the families, because this has also come up in a big way. Side by side, the assessment has entirely changed. Now we cannot have a practical examination in the different hospitals. So assessment has to come as an online thing. That is my take on.
Professor Hidalgo, how it has changed in your country? Sir, unmute, sir.
Muted.
You're muted, sir.
Definitely, the pandemic puts in a position that we forced to change. And also it became to realize that the medical education definitely is a vulnerable asset, and definitely we need to try to see what is going to happen in the future. Of course, we need to we adapt our curriculum to what is happening, more to the online process, and I believe we are going to see more changes in the future. I mean that definitely the adaptations of the curriculum was forced because of the pandemic.
Okay, Shastri sir.
I don't know. My suggestion, whether it will go down well with with Dr. Govil and other people who have been running the training program in the society. When we are making the entire examination process online, and online itself, I become more tired after taking an online examination than I would perhaps after 8 hours of working in the ICU. So it is a huge stress. If it is a stress for me, it is all the more, the stress is compounded for the candidate. And that is why it is likely that even though our examination is very structured and the examiners are pretty well versed in assessing the students' capabilities, and they factor in the nervousness and other parts to it. But I have to admit that there are occasions in which a person is not able to produce his best in the examination. Could there be some additional methods like what we are seeing right now in ICSE and CBSE and other things, that they are putting more emphasis upon internal assessment? I don't know. It is a absolutely uncharted territory. So I'm quite open to any kind of criticism. But since can we include some kind of internal assessment, the way the DNP people have started doing it right now, that we do some kind of mock test at intervals, and maybe send a feedback to the ICCM, so that that is also factored when we actually give out the results. I don't know. I would like Deepak to give an opinion on that.
Deepak, sir.
So I agree with you that CBSE and ICSE is doing, but if I just remind you that DNB, the FET examination is not being factored in the final examination. So it is just a self-assessment. That's it. It is not, the marks are
dummy,
not being.
Yeah, it's a dummy run to ease.
Yeah, I agree. So that is why I'm saying that we can take that as a cue and then maybe include that in the performance assessment, even just prior to the examination. Patient comes with 0.1 mark on the examination.
Sir, if you allow, I would ask Pradeep sir to answer this, maybe being the Vice Chancellor of the college.
Yes, I agree that formative assessment should always be a part of any course which before we go for the final examination, because that keeps both teacher as well as students alert throughout the year. Because once you start doing that kind of formative assessment on every quarterly basis or on every 6 months, definitely the performance at the end of the year you get is always better as compared to taking one exam at the end of 1 year. So I agree with that formative assessment should always be a part of any course curriculum which you are doing.
Okay.
And maybe we had a discussion sometimes back, sir, that you also agreed that a very good, your well-structured e-logbook and internal assessment or the formative assessment on a regular interval would be quite required to give an overall holistic structured process itself. Farhad sir, very quick comment on this.
I've sort of been involved in this education of critical care right from the start, and I sort of helped the initial curriculum of the ISCCM and the DNB. I'm not a great fan of curriculum. I mean, it's fine to have a curriculum, but at the end of the day, you teach what needs to be taught. And, I don't necessarily checkbox the whole curriculum. See what is the, I mean, obviously over a year, you'd like to finish everything, mechanical, ventilation, shock, and so on. But it'll happen by itself. So while I think it's nice to have a curriculum in the background, I don't think I've ever looked at it after writing it down, because you can sense where the strengths and the weaknesses are in a given group of people and concentrate more on that. For example, in the early curriculum, there was nothing of how to read RCT, and it should be there, but without it entering the curriculum, we started doing it. So that is my first point, is that while it's nice to have a curriculum and it's nice to be updated, ultimately you got to teach what is the need of the hour. Now, in terms of passing, failing, this is a little tricky. When we did the first ISCCM exam, I actually sat the theory paper, Jiggy had set it, and I said, anyone who can answer the questions the way I can should pass. So there was a sort of vague benchmark, so you didn't have to have a perfect answer. I didn't know the questions. And I made it very clear that if someone failed, there should be a detailed explanation to both the candidate and the teacher why they failed. You couldn't answer this ECG, this was a MI, you called it a SVT. Somehow that seems to have got lost. Now, of course, when we started, there were just 10 or 20 candidates. Now we have 100, so it's much harder. I think feedback to the candidate, genuine feedback, because the people who in my institute have not done well, honestly don't know why they haven't done well, and they don't know how to seek redressal. So I think we should go out of our way to explain to the teacher and the candidate so that they feel that, this was a fair assessment, Now, internal assessment is useful, but again, from a personal point of view, our teaching, our research is all is purely non-remunerative and at our spare time. Holding exams is not the easiest thing in the world. I don't know how we're going to hold 4 exams a year and so on and so forth. I think what I would like is what Dr. Shastri said is maybe what you can do is send an internal report before the exam. And for the borderline candidates, before you actually fail them, look at that report and see, this person actually may know things and is not performing today. Maybe that's something you could do. But otherwise, internally, you're going to favor your own internal candidates.
Yes,
That's the reality of life. Yeah. So you're going to say, this is the best person I ever know. And you're not going to say, So that I think in that sense, it'll be slightly self-defeating.
In fact, just to substantiate the thought of Dr. Kapadia, I fully agree that whosoever candidate in exam fails, there should be at least explanation for the candidate officially or not. I think officially, or even can be told whenever it is appropriate, but should be told that why he failed. And that, and particularly when we appear in international exam, if we pass, we are also told that we are passed immediately, and most of the time. And if we have failed, we are told that why we failed, and that looks very transparent and fair on the part of the examiner and candidate as well. That he knows why he has been failed and what is the minimum thing he needs to know at least. So I'm very strong advocate of that philosophy, and it should be implemented.
I will go back to Pradeep sir.
No, Deepak wants to say something. Deepak wants to say something.
So I just wanted to clarify here that as Dr. Farhad has rightly said, the tradition of sending the comments of examiner is still there. Whenever a candidate fails in the practical exam, IACCM officially sends the comments. I agree that few comments are not up to the mark as they should be. They are little generalized, but few examiners give very precise comments. And 3-4 years back, when I was looking after exclusively the exam part, we started to have some observers to exam as well. So we appointed few senior faculty members to go there. That time physical examinations were there. So to go there and observe the exam, they were not taking any part in the exam. They were just sitting quietly. We did that exercise one time, and the committee report was incorporated in the exam pattern as well. And this year, since last year, we are having the Zoom-based online examination of practical as well. So all the recordings are there. And this year, we are going to propose to audit few recordings anonymously. So like the result has already been out, so it won't carry any bearing on the results.
Sir, you are also telling that you would be also doing that, right?
And prospectively, we can think of appointing again few observers to just
will
observe.
It be only a senior? Why not upcoming examiner? That person can also watch.
No, upcoming examiner is already observer. So anybody who wants to become examiner has to be 2 years teacher for 2 years or 3 years
and also
college. And also he has to attend at least 1 or 2 sessions as an observer to become examiner. So it is
Yash,
already there.
Yeah.
I will go to Yash.
Yeah. One point. See what is happening. Few centers are center of excellence for critical care, but sadly they miss one segment of critical care totally. Say some hospitals are missing trauma totally. Somebody is missing poisoning totally. So the curriculum is well designed, no doubt about it, but we know what is amiss in our hospitals. So those candidates could be given opportunity to take up that particular segment at some other hospital. Probably that would have been happening. And skills, especially non-clinical skills, aptitude, interpersonal skills, team dynamics, this should also be focused in the curriculum as well as in the assessment of the candidate. One last point is there has to be individualized learning. Most of the courses now are trying to do that. IACCM cannot do it on its own, but the center head, the teachers, they know what the background of their student is, whether it is anesthesia background or pulmonology or medicine. So they can probably draw a roadmap which is better suited for individualized training for that particular candidate. But that belongs to the center head, obviously.
That's a good idea, that a very individualized training sort of roadmap for every individual candidates depending upon the background and the level of experience they have come. I will come back to Pradeep sir. Sir, you had some ideas of getting an examiners boot camp, a teachers enclave or something, some sort of teachers manual coming up with, so that, and also a feedback from the examinees itself. So can you please share that, what your thought processes are?
Yes, actually, that should be a regular part of our teaching and training program, that is train the trainers. Whomsoever is working as a teacher, like our Medical Council of India, they have started courses, and they have started.
Yourself has taken the course, right?
Yeah, I already have taken 2 courses. One is a basic course, Basic course is of 3 days duration, and in that there are teachers who teach the teachers, basically train the trainers. The course is like that: train the trainers or teach the teachers. So every part of your not only making the curriculum, but also how to train and how to evaluate, the three parts of any medical education. That is, first is making a curriculum, second is training and education, and third is evaluation. In all these three parts, the focuses are given on various issues, including research. And they have made it in three parts rather. One is basic course, and that is a 3 days course. I have done it long back, I think 10, 12 years back. But after that, I took another one, that is revised basic course. And after that, in 2015-16, I did the advanced course in medical education, ACME, that we call it as an ACME, advanced course in medical education. And that is a 1-year course for all the teachers. So we need to get enrolled in nodal centers of Medical Council of India. And in all those nodal centers, 1-year training is given on 12 different subjects related to medical education and teaching. And every time, like research, when we are talking about research, so 1 month goes for research only, and they teach us how to do qualitative research, what is quantitative research, how the statistics, epidemiological research, critical, even we just need to take topics and everything. So there are 2 contact periods in between, 15 days in the first 6 months and then 15 days. And it is an online continuous course. Every day they float questions and you have to answer depending upon the course which is going on or depending on the topic which is being discussed. And you need to give answer. And every day you have to give at least 2 to 3 hours to complete
quite
that.
a difficult time for the teachers, actually.
Yeah, it's a difficult. And but that makes you perfect. That makes you perfect.
That adds to the perfection. Very quick, yeah. I'm interrupting you, sir. Professor George, anything of this sort in the US system, your experience?
Well, actually in the Society of Critical Care Medicine, we have the boot camps, no, and especially with the idea to, as you say, to strategize how we are going to do exams. And of course, one of the key points is how we are going to present the traditionally hands-on training and to adapt to new systems. I mean that definitely the boot camps is something that is being used, and I believe it's going to continue to be used a lot, and especially as Dr. Pradip is saying, to trying to train the trainees and trying to disseminate the knowledge, you know, in a more comprehensive and online way.
So as we both have the president and president-elect as well as the vice chancellor is present, can we expect some sort of train the trainers or a train teacher examiners boot camp? Can we have some sort of programs in near future?
I think so. I was planning to discuss in this board meeting, which we are going to have very soon, next month, with the permission of chair. We'll put this across the board that if we can start such boot camps for our teachers.
And make it mandatory for most of, maybe in a couple of years, it would be mandatory for the teachers and examiners to go through.
Yes.
Yeah.
Yes.
Definitely. Deepak sir,
we tried to start this workshop 3 years back, but the problem was that attendance was very poor and very less prospective teachers or examiners turned out in that meeting. So we did a 1 day in Best of Results and 1 day half-day meeting in one of the conference, but national conference, but very
maybe if we can keep it separate.
No, we can discuss that later on.
Definitely.
We'll discuss that. Yes.
Definitely on that. So coming to the last point in this one, and then I would go to the COVID specific things. 2 points I just want to have a very quick A. Do you think that we should also now look into training the critical care super or subspecialties, whatever you say? Because now if you see the anesthesia, for example, or medicine, both have differentiated into super specialties. So is it time for a critical care super or subspecialty training also be given separately. We have already initiated the neurology as well as the extracorporeal life support, to some extent the ultrasound. But do you think the other subspecialties are also to be included? I would start with Shastri sir and then quickly to all of them.
I think we can't avoid it because that is the way forward. Most of the specialities, they tend to sort of break up into subspecialties, and that is where they manage to get their consultants to focus more upon particular subspecialties. We are making an attempt in our hospital to bifurcate the neuro part of it completely from, but it will remain under the overall critical care medicine, but it will be separate. So I think that is something which I think we have to get used to. Deepak, when he went into predominantly gastro ICU, I remember that was the time when this particular thing was anathema for me, because I mean, I couldn't believe to confine myself into such a specialty. But that was a time when probably it was slightly premature at that time, but now I think the time has come for us to branch out into particular specialties. We ourselves over the years have gone into our own interest in which we have made a name for ourselves. So, I mean, this is an evolution of critical care, and I think it is a matter of time. Most of the universities and most of the centrally funded institutions, they don't need permissions. They have already started. PGI Chandigarh, All India Institute, they have started running postgraduate DM level courses in neuro anesthesia and critical care, and lots of other institutions. The private universities are going to follow suit. So I think whether you like it or not, this is going to happen in the next few years.
Yeah, Farhad sir.
Well,
different views, sir.
Well, what's actually happened, if you look at critical care, from becoming cardiac ICUs to respiratory ICUs, renal ICUs, is generally moved towards more general ICUs, because ultimately what we do is the same, right? I mean, the underlying disease might be a subdural hematoma or a myocardial infarction, but you don't need highly specialized subdural or myocardial infarction still. So the trend has been towards larger and larger general ICUs than towards smaller and smaller highly specialized ICUs. So, I mean, I don't think it matters too much whether you specialize or not, as long as the basic strong intensive care part remains the same. There is very, very few interventions which improve outcomes which are not general ICU and are highly specialized. Now, obviously, in a neuro ICU, you need a neurosurgeon to go in and, drain a subdural. But the basic critical care part, you can have a little bit of ICP monitoring and stuff like that. But in terms of specialized ICUs, I don't know any ICU techniques which are known to overall improve outcomes compared to the standard techniques used in disease A, disease B, disease C. And the trend I've noticed is that the ICUs are getting bigger and more general rather than smaller and more specialized. So I don't know what's happening in other people's institutes. But the days of, a 5-bed coronary ICU and another 6-bed nephro ICU and another 4-bed.
More of a general which can cater to.
I don't see that anymore. And that was
Professor Hidalgo, your take.
Well, as you know, our normally especially in America, the tendency is to have a super specialized ICUs. But of course, in South America and Central America, the reality is different, and we are most, as Dr. Farhad is saying, focused on the foundation of the critical care specialists, and we are more general ICUs overall. 80 to 90% in South America and Central America is general ICUs.
Maybe it all depends on that how differentiated is the institution is. A bigger institution with all the super specialties will obviously dictate with their own individual, very super specialized ICU. But overall, a proper intensivist should have a overall knowledge on that. Yash, do you think, the last question on the general part, that we should start learning all the other skills like you were talking about? Communication, professionalism, a little bit of management skills, teleconsultations, EMR, quality, safety, accreditation, and all this. Because these are all integral part of our daily practice. So we have not covered them yet. So do you think we should have a little bit, give the students an idea of all those parts?
Yeah. As Dr. Shastri pointed out, we are not going to just make the students pass the exam. We have to make them the consultants. Right. So these are the duties of a consultant. This comes in our charter in our hospitals, that you are bound to do the quality work. You are telemedicine. We all are doing it now by wish or against our wish. We are spending more and more time. Safety. And we have to diversify ourselves. We have to take the ICU as well as the hospital ahead. And these skills are much required for any progress of critical care in any hospital setup. Depending on how big and how diversified your hospital is, these non-clinical or non-academic skills might differ. But these skills are must to have now.
Yeah, definitely. Pradeep sir, your take, and then I will go to the COVID related in the last 15-20 minutes.
As far as ICUs are concerned, I think more and more you divide, more and more resources you need to arrange. And that is one of the most difficult part as far as opening more and more ICUs are concerned. Secondly, when we are talking about this,
the other areas of training like communication, safety, quality, others.
Yes. So in that context, I wish to say that there are two things which we have to understand. One is clinical leadership and another is healthcare leadership. Okay, when we talk about clinical leadership, we all are experts in our own field. That is, if you are an intensivist, you are very good at intensivist. But to become a good leader, you need to learn a little bit about healthcare leadership. And healthcare leadership teaches you about a good professionalism, how to handle your ICU, how to do good administration, how to improve quality, how to take care of the infection control, how to take care of the manpower, and all those issues related to administration. So here I wish to say that every clinician should at least take some training as far as healthcare leadership is concerned. And then only this thing is going to be possible in future.
Deepak sir, quickly, then I will go to the COVID part.
I'll need 1 minute.
Yes, please.
Deepak, you say.
No, you please continue.
Right. So just to extend the thought of Dr. Kapadia, I have another view on the super specialty hospital and super specialty ICU and general ICU. Most of the time, super specialty ICU are placed in to satisfy the ego of the concerned super specialist, because that super specialty wants his identity as a whatever specialist he is, and he wants someone. And if I see the quality of the care which is provided by the intensivist general care, and if you go to super specialty hospital, it will look like that it is your step down unit like SD or something like that kind of care it is. And whatever super specialty ICU I have visited, I would not like to keep my patient on a priority in that ICU. So that's another aspect of the super specialty ICU are there, not really. Mostly, as long as you are not going to teach somebody how to do cranectomy or how to do intervention as a DM of resource courses, just talking about all medical management is not going to help. So if in that course, like suppose you are having GI expert as an intensivist, and if you are going to give that liberty that he's going to do endoscopic procedure or all the procedure which gastroenterologist and gastrosurgeon does in emergency, then there is a point in putting a DM course in that. Just making them more refined for 3-year courses in critical care in that branch, I don't think is going to serve the purpose. But there's one extension about that. The soft skill development, what the word I'm using for all kind of communication, care, communication among other patients and other things, is the most important part in current perspective, when more and more we are going to provide where patient is going to pay us. The patient, wherever patient goes, when he's paying, he expects the service right from the entry up to your. So, soft skill development will become an important aspect of the course and curriculum to make someone as a complete doctor. If you do not have soft skill development or soft skill in you or anybody of you, you have to learn to become a good person, a good doctor. So, there is no substitute for it. You learn from institute or you learn from yourself. We have learned of our own because we needed to do that. But I think it's a time is there that soft skill development should be the part and parcel of the curriculum, and that precisely the reason in coming conference make it
To
aware,
include
to
a lot of,
include it. We are going to do free soft skill development workshop for all our doctors. So this is going to be the part and parcel. Those are two things I have to put. Pradeep, you want to say something?
Deepak sir, then I will come to Pradeep. Deepak sir, I interrupted him.
No, I agree to a certain extent with Dr. Kapadia. That 11 years back, when I was given this option to choose a particular segment of gastro and liver transplant critical care, I was also in the dilemma, and I discussed with Dr. Shastri whether we should go it or not do it, because I was a little jittery to restrict myself to a particular subspecialty. But having said that, going back, if I look back in 11 years, I have learned a lot, and that I couldn't learn if had been a general critical care, because a type of patient, type of repeated patients, same patients, you learn, and then it becomes a reflex. The management becomes a reflex to everybody what to do. And everybody wants to go to a specialist who is having maximal experience. Tomorrow, if you want to go to a neurosurgeon or a laparoscopic surgeon, you will go for that surgeon who has done the maximal cases in that specialty. So same way, but I agree, the 3-year curriculum for a super specialty critical care is still a distant dream. Of course, after a 2 or 3-year curriculum in critical care, one can go for a 1-year super specialty training, or not training a exclusive experience. I would say rather than training, it's exclusive experience, yes, which can be there.
So that exactly my point was that to compensate for that the missed opportunity that we didn't have in our institution, can we have some sort of 1-year exclusive experience on a critical care super specialty? So maybe we will, in coming days, ISCCM will take care of that. Dr. Pradeep, very quickly, sir, we're running short of time.
Yes, actually, if you look at the trend, the way we have grown, intensivists are known as multi-organ doctors. And when we say all super specialists, they are called single organ doctors. So what is the problem? That more and more single organ doctor, more and more tubular vision. So if you, as an intensivist, and if we want to practice a good intensive care, do you think that we'll be doing justice with our patient if we are focused on particular?
Sir, we are not deviating from our, sir, we are not deviating from our multi-organ system. So we can be a multi-organ with a single organ supremacy. So
I'm coming to that. I'm coming to that. So what I mean to say that it should depend upon the organization, institution, and wherever you are working. It is not that it is in a small town you are making super specialty ICU. Obviously, in a city like Delhi, we need it where liver transplants are done, heart transplants are done, everything is done. We definitely need that kind of ICU. But in general, if we make a ratio of 80-20, 80% general ICU, 20% around super specialist ICU. In that way, if we see, yes, it is the need of everyone knows that with the passage of time, we are going towards more and more super specialty things. It is needed in future.
Maybe. Okay. So very quickly, that ISCCM has decided to come up with a basic and advanced course for the corona care. So we have proposed the name as Basic Evidence-Based Corona Life Support and Advanced Evidence-Based Corona Life Support. And to help me on that, we have two young people amongst us who has helped me to draft the very basic idea, but it is not finalized. It would be finalized taking feedback from all the seniors. Is Dr. Balkrishna Nimawat and Dr. Sudipta Mukherjee. And we have also taken reference help of almost 30 individuals from all parts of India who had been not many senior, but they had been in a mid-level who has fought COVID in the front. They have treated thousands of patients in critical care, moderately experienced, and have the zeal to create a new course itself. So my question to all the seniors would be that in the basic what we have thought that it would be a one-day program, not more than 4 hours to 5 hours, with all the standards and an online-based program with the pre-test and post-test format. Do you think we should target only a non-critical care physicians, or should we also include the nurses and allied healthcare profession? Shastri sir.
We have started this exercise in our hospital already, and we are not making any distinction between any healthcare worker. We are saying that anybody who is prepared to spare time is welcome to join the program. It is basically, was an offshoot of the directive that came to us from the Delhi government that we need to have a blueprint from your hospital as to how would you prepare for a possible third wave. So in that possible third wave was a huge demand that we thought in the department was the skilling of healthcare personnel who can look after the needs. And this soft skills was very important, very high on the agenda. And we thought that possibly the kind of empathy that the nurses have, maybe we could include them in the communication also. And that is why we have made this program, which is almost finalized for any healthcare worker. We will obviously prod and push some
definitely, I will take a lot of support from you, sir. I will input from you on that part. Okay. Regarding the components, I will come back. But first, the very basic question and quick answers. So you support that it should be for all, universal.
Yes, absolutely.
And just like a BLS, anyone can learn.
Yes, absolutely.
Paraj sir.
You know what? It's fine to have a course, but ultimately what you need to deal with the third COVID wave is to have nurses and doctors who are familiar with intensive care. Just absolutely no way out of that. And as far as I'm concerned, COVID care and intensive care are 99% similar. I mean, use a little bit of steroids, tocilizumab, we might use some antibodies, but otherwise there's nothing very different. So while I think it's a good way to familiarize people, it won't solve the problem of the third wave. I mean, the third wave, you need a well-trained, already experienced force. My only concern is there are so many thousand courses that how does this become not 1,001st course? What is different from the others? Why do we need a certification? I mean, I'm all for courses, but then somehow the course becomes the target rather than, translating it to the bedside. If I had to design a COVID course, I don't see what would be different from designing a non-COVID course, frankly. I don't know what I would be saying differently other than, the PPE part of it.
Maybe, sir, a little more your evidence-based or the things that really do work, if that can be translated to the community, right?
I accept that. But let's take the example of the ISCCM guidelines. I mean, I don't want to be discouraging, but some of the guidelines were horribly non-evidence-based. But they were consensus-based. I, as a member of ISCCM, I'm still embarrassed by the fact that we recommended HCQ so heartily. And how will we not make similar issues when we do our course? Right, I mean, evidence-based medicine is a part of general medicine. So what we can say is the evidence base for COVID is 1, 2, 3, 4, 5. I mean, that takes like 20 minutes to get across. The rest is standard.
Deepak sir? Or maybe I'll come to Yash and come back to Deepak sir.
If we talk about COVID course, we also designed a course last year, CRISP COVID course, which was a totally online, but we designed it, say, 2020, August, the course was launched. It was a totally online course. There were few takers initially, but as people were educated, the takers were less. We are doing a course with HSCC, which is an ongoing course for last 9-10 months now, and all healthcare providers can do that course. But the clientage for that course is basically tier 2, tier 3 and smaller cities, right, where people are not having opportunity to learn. Right. So we have to target our audience very, very judiciously. And the intent should be to educate them on basics as Farhad sir is keeping. Some of them have to be upskilled and some knowledge part has to be added. That is the most important thing which we have to do. So certificate
knowledge maybe, right? Yeah. We are no short of knowledge. Rather, rich knowledge is
reskilling them and upskilling
reskilling them and skilling them in a way. Pradeep sir, because you have trained so many in your state, in both the states. So your take on it, sir.
Yeah, actually, we are running courses for not only doctors, but nurses, paramedics, and all those who are attending these COVID cases. And they're coming in groups. I mean, every 1 week, they come for 7 days and they see, because still we have 9, 10 COVID cases in our ICUs. So they come and see how the things are done, and we teach them about the basics of management and ventilatory care and other theoretical aspects of COVID management, all those things. They stay there for 6, 7 days, see everything and go. So making a course, comprehensive course, which you are saying, just like ACLS or FCCS or this kind of course,
right, sir.
Obviously, there
and
is
that's
not
on the societal platform where we want to disseminate the proper and right knowledge to people who are who intend to go through it.
My only concern is that if we look at the evidences, there are very few evidences.
And most of them are conflicting.
Most of them are conflicting. So when you make a course, that means you are going to imbibe in the trainee's mind that yes, what you are saying, that has to be followed, whatever the situation. That means you are talking about some standards, isn't it? Like ACLS course, we have all standards. In FCCS, all standards are there, what we teach, because they are all fixed. There's nothing much to change, and all are evidence-based.
Right,
so
sir.
Here we lack evidence. I don't know how to formulate it, because on controversies, with all controversies, can we formulate a course? We have to think. I think we have to do a brainstorming for this.
Right, sir. Yeah, Yash, you wanted to...
Yeah. When we are designing this course, what we faltered at was could not change the modules. Like we had plasma therapy modules. So we have to make it like a living document, which we could be able to change as the evidence grows in favor or against a particular modality.
Right.
Another important point, we have to be very, very careful and lot of brainstormings, because we have to keep pseudoscience away. Even many good journals and organizations are proposing some therapies which are hardly evidence-based. So we have to be careful.
Rajesh bhai.
Yeah. Actually, why we thought of making a basic course? If you see the pandemics and see the care, none of us can deny that 80% of the patient care were given by the people who were absolutely not trained or just training. They have little idea of even how to put oxygen when they really came into picture of providing the care. So our purpose is not to train them how to treat the COVID. Our basic purpose is they should recognize how to give oxygen. They should recognize how to give IV fluid. I tell you, there were nursing staff, there were all the doctors, non-MBBS, all the Ayurvedic, homeopathy, all kind of general practitioners jumped into providing treatment. Everybody open, hospital mushroomed up. But most of the time, we were getting patients who were not treated properly, or treated properly, then were not given appropriate treatment, and everybody was doing what they wanted to do. So basic purpose of our doing basic courses, just take example of basic life support. When you train somebody to do cardiac massage, a general public, you don't want them to become a cardiologist, or you don't train them to do the proper. Only you want to buy the time properly till they keep the patient alive. Same way, our purpose of doing basic module to train all those who are involved in managing the patient at pandemics in masses, and then how to do the basic things correctly. So that's why 2 modules will be there. One is the basic, one is the advanced. When we talk about advanced version, it will definitely go with very strong brainstorming with all the stalwarts of IS system, what to say, what not to say. But the basic course purpose which we are conceptualizing, which our thought is to train in masses, everybody, how to do the things, basic things correctly. That's what thought we have. Dr. Kapadia, now your input I want.
How will this course be different from a standard ACLS or FCCP? That's what I mean. That's what we do
So
during
we are not going ACLS. We are going to talk about very basic things.
No, yeah, but okay, say FCCP. I mean, these courses already exist, right? We just have to tweak it minimally, because basically what we want to do is, please do this till someone who knows what they are doing is helping, which is the point of, say, FCCP. So it will be the equivalent of FCCP, which I would completely and thoroughly and totally agree with. I mean, if a sort of, how do I put it, mildly modified FCCP for the COVID epidemic is done, I totally in support of that. But my whole point is, it's going to be standard FCCP. It's not going to be COVID FCCP. There's nothing COVID about the...
Sir, in due course time, it will get conceptualized to train the people at broader level. Because
I'm all for that. I am totally for that.
I know in the class, I mean, if you don't talk about the Mumbai, Delhi or Ahmedabad, if you go down further, if you go to C and D class city, all the treatment, all the basic care to the patient is being provided by all Ayurvedic, homeopathic, and even sometimes only nursing staff and others. And honestly speaking, if we just can sterilize certain things, which we feel, not everything we can do. Probably it's going to make a major change, at least the patient. And suppose, for God's sake, anybody lands up in a condition who wants to buy some time, if that treatment is given properly, you save a life. That's what the purpose is of this course.
Absolutely.
We are not going to make anybody a specialist. We really want them to do their job in a meticulous and proper, do the basic things correctly. That's what the purpose is. That's what
Shastri said.
Farhad, the only difference between your approach and Rajesh Mishra approach is that in the name of COVID, it's going to sell and you are likely to get more audience. I think I agree with you completely that the basic things that we are going to teach is no different from what we teach in other courses. But COVID is the flavor of the day. And for COVID, you will get funding. For COVID, you will get support. And so in the name of COVID, you will obviously pass on the message of what is basic intensive care.
I grant that. Is my concern is there are so many already, say, the task forces do it this way, the guidelines say do it that way, AIM says do it this way. How do we become something different from that?
By adding the name COVID to it.
No, but we have the COVID task force, the Maharashtra COVID task force, the Central, the Supreme Court task force.
Sir, again, those task force have been made keeping in the mind the people who are providing healthcare at consultant level. What we are talking about, we want to train the last person. We want to make a course where how our nursing will give that care. Even probably this course may be applicable to paramedics who are like involved. So
again, I want to specify. I couldn't agree more with an FCCS type of course as being the hour or the need of the day or the need of the before the third wave. It would be absolutely outstanding if we could get a large group of people, have a very structured thing. This is how you look after a sick patient. This is how you transfer a sick patient.
That is precisely, sir. That is
absolutely.
They're not going to make anyone COVID expert. Just be very clear. They're not going to. And in fact, that thing will be utilized in due course for anybody's care. It's not like that COVID. We are making a COVID because right now, on the name of COVID, you can sell anything. That's what the problem is. So later on, you can make it as a general thing for, and it will become a ISSM initiated course module for training our paramedics and nursing and all our allied health services.
And what about, if I may ask, I think we need to close down the day, that we have a consensus that maybe a well-designed basic course which caters to the last mile and not adding up to the confusion, backed by evidences, whatever little of evidences we have, and which imparts the knowledge and skill of doing the basic thing, and more importantly, not doing the incorrect thing to a patient, and that would be of great help. But we are facing a lot problem in constructing or putting the components in the advanced course, in fact, because the proven science of COVIDology is still incomplete, evolving, and at times it is contradicting. So I need your support and very quick points that how to solve this conundrum. Shastri sir, you can start.
I think you can start the course with a sort of a disclaimer saying that at the end of the day, what you need to do is, first of all, please do not do any harm to the patient. and the rest of the things, simple ballpark critical care is what is going to save the life of the patient, rather than fancy things that we have tried and which has not worked in several patients. So I think that is something that you have to mention right at the very beginning, that what you need to do is make sure that you do what you do for every patient, and that is maintaining perfusion to the organs, keep supporting the organs, and hope that the underlying pathology is not cured by your medications, but better by the defensive or restructuring abilities of the body itself. I think that is the basic physiology that you need to mention, that what we are doing is that we are supporting the life of the patient and we are allowing the body to heal itself.
Okay, yes, in fact, Arindam, rather than using the evidence base, we should discuss that we are going to discuss the basic thing, basic correct and basic physiology, what Dr. Shastri is saying, to extend that physiologically we are going to teach people correct things rather than talking more about evidence, because the class of the healthcare worker or allied doctors they are targeting, they will not understand the word evidence, they will more understand the word physiology.
Right, that was on the basic. Yeah, we are talking
about... right now we are focusing only on basic, Arindam. Advanced probably we need to do more brainstorming. At least we should come out with the basic immediately, and that's what thought is, because the basic thing which we want to correct right now.
Fair enough. So I will take a concluding comment from each one of you. Yash, your concluding comment before we close the session.
For the whole of the meeting today, I would say we have to teach our students art and science of medicine, both things, and online media has come up in a big way. Many things are good with online media, interaction is easy, but there are some roadblocks which probably we have to overcome as a team. And there is globalization of knowledge and there is free access, those are good things.
I don't really have much to say. I think we live in a time where finding knowledge, finding expertise, finding guidelines is very easy, and make the most of it by whatever new changes the pandemic has brought about.
Shastri sir.
I think I just want to rekindle the rekindle the passion that perhaps we had in the beginning of our career. That kind of a passion, if we are able to generate in our trainees, I think we would have done our job. And finally, when it comes to COVID, yes, a basic course is very much on the order. We can possibly do that simply for the reason that we'll get a lot of takers, and in the process, we can improve the intensive care management as a whole, rather than not just think about COVID itself, but COVID could be a good platform for that.
Pradeep sir.
I think when we talk about basics, what we need is three things. One is basics of oxygen therapy, basics of ventilatory management, and third is basics of basic life support. And these three things, if we can combine, we can make a course. And that is what we exactly need in this basic management of COVID. Rather than teaching about giving Remdesivir and Tocilizumab, we are not going to that. These three things, if we teach properly, it will give a very good message to the entire society.
Definitely, sir. I will get back to you and in detail about it.
Right? One more thing we have to add: avoiding the drug error, because drug error was one of the biggest problem which had happened, and we should design a very very structured, simple thing how to avoid the drug error, because that is one thing that still not. Sorry.
Do's and don'ts.
Drug error is one thing which we have to focus a lot, because a lot of people will come and due to prescription error, dosing error, they have not known the drug, some reason. A lot of patient has, I feel has died in COVID because of drug errors.
And to that I'll add infection control practices also. What happened in the second wave was
in fact, if Dr. Deepak agree, he can propose a panel for structuring the course for next 1 week, and they can suggest their suggestion, and then we can launch. Dr. Deepak, if you can agree, you can make a board of this organizing the course, and then we can go ahead.
What I am waiting is let Dr. Arindam submit the basic structure of the course. Then it will be vetted by the few experts. Otherwise, if we give the job to few experts to make the course, then it is very difficult for everybody.
Okay, fine, fair enough. Infection control practice, another thing
so
we should include.
Let the basic module come, then we will circulate with a few experts, and then we'll take it forward.
Definitely, sir. Sir, please give your concluding remarks and close the session for tonight. Deepak, sir.
So as I have heard all the experts, certainly there is a need for basic course. Advanced course can be taken on a little later because we don't have got much evidence. So advanced course can wait, but we can roll out the basic course in a few weeks or maybe a month's time. And there are certain suggestions to modify our examination system and the internal appraisal system of students. We can discuss that in our college board meeting and take it forward. That's it. And on the behalf of Indian Society of Critical Care Medicine, I would like to thank all the panelists for sparing their valuable time and taking part in this discussion. And would like to thank all the delegates who have attended this session and put their views and questions. There were a lot of questions and views in the chat box there. So thank you very much and good night.